Hello, my name is MarkAlain Déry. I'm an infectious diseases physician and epidemiologist here in New Orleans, Louisiana. Despite significant progress in HIV prevention and treatment, disparities persist across different populations. This roundtable that we are going to have today brings together three distinguished HIV experts and stakeholders to examine the complex factors driving these inequities and explore strategies to promote health equity. By fostering open dialogue and collaboration, we aim to identify actionable steps to address HIV disparities and ensure access to quality care for all affected communities. The insights and perspectives that our experts will provide here today will be invaluable in shaping a more just and inclusive response to the HIV epidemic. And with that, let me please introduce our three panelists today. First up will be Dr. Monica Gandhi. She's an infectious diseases physician and professor of medicine and associate chief in the Division of HIV, Infectious Diseases, and Global Medicine at the UCSF School of Medicine. Dr. Sneha Jacob is an associate professor of medicine at Rutgers University, Robert Wood Johnson Medical School, as well as an HIV specialist with a background in internal medicine. And Dr. Hamadullah Shaik is an assistant professor in infectious diseases at Rutgers University, Robert Wood Johnson Medical School, and is associate chair for infection prevention at Robert Wood Johnson. Please, let's give our panelists a warm welcome.
One thing that I personally have noticed when it comes to the stigma that is, associated with HIV or PrEP or, people's, sexual orientation. I mean, it's I think twofold. One is their own personal life, and one is how comfortable they are with their own physicians, right? And that is something I have learned over time, that if they can get a physician who doesn't judge them for who they are or what they have, and just treats them, I think their readiness to listen to that physician increases. And the compliance increases, and that is what I have noticed in my own practice, because there was this one patient that I have who actually came to me because his primary care physician didn't really show much interest about prescribing PrEP, right? And now, as Dr. Gandhi was saying, when it came to contraception, everyone could give it, and so is the case with PrEP, right? You don't need an HIV physician or an ID physician to give you PrEP, right? It's part of your preventive medicine. Anyone should be able to give it. It's not like you have 1,000 drugs to choose from. You will literally have 3 drugs. Hey, just give any one of them, right? It's not like you have to keep monitoring them every month, every 6 months, every 1 year, get some labs, and you're done, and that's it. And so that was one issue that I noted, and that's why there was a lot of interest in PrEP when it came to our clinic. Secondly, what I try to do is that, especially with my PrEP patients and my newly diagnosed HIV patients, I try my best not to do televisits, right? I think that connection early on is much needed, and that especially with the newly diagnosed HIV patients, because they're already, mentally they are in a place that I personally can't understand, right? Because they've been diagnosed with a new condition, and you're telling them, hey, listen, in order for you to stay alive, you have to take a pill for the rest of your life, right? And then you have to hold their hand in that situation. And I try not to do a lot of televisits with these patients, and I think that creates a good connection, that creates a good chemistry. One thing that one of my attendings taught me during fellowship was that whenever you get results for patients with HIV or PrEP, don't let your clinical staff tell them. Call them yourself, so that they build that trust in you. And that is what I usually do. If there is a positive test, if there is something that they have a new STD, I call them myself. I don't tell my clinical staff. Yes, I tell them to, hey, listen, now I've already told the patient, now can we schedule them, this and that. But I try to call them myself and try to talk to them so that they build that trust, so they know that if they are being stigmatized in their personal lives, they are not being stigmatized as a patient with me or with our clinic. And I think I think that has really done well for our patients. Lastly, the thing is that it's again, especially with PrEP patients, and especially PrEP patients who have risky sexual behavior. I think one thing that I try my best to do is to screen them for STDs everything. Like without fail, I tell them, hey, listen, you don't want to see me, don't see me, just come in for a nurse visit, just do the swabs, do the urine test. I'll test you for syphilis again. And now over time, I've been doing a lot of doxycycline PEP, which has been, surprisingly, I've seen a lot of good response, a lot of positive response. More and more people are asking me for it. And I hope that's reducing the number of STDs in them as well, along with PrEP. So it's really and one thing that this is the last point I would say regarding this is that you tell them data that is backed by CDC, you tell them data that is backed by research, so that they don't just believe what I am saying. They can actually believe the bodies, the federal bodies that are making those recommendations, right? So I think that really matters a lot. I mean, if I were a patient and if you were giving me something, an antibiotic, and just saying this is what you've seen in your clinical practice do versus you're giving me good data on it.
But Dr. Jacob, just so that we can wrap up this section, just how do cultural factors or stigma surrounding HIV and AIDS create barriers to access HIV testing, counseling, and these prevention services that we've talked about, specifically marginalized communities? And how do you and your clinic system, your FQHC, your Ryan White program, address those issues?
Yeah, so it's been a really interesting discussion, and I do find that in our clinic, the barriers include language barriers, as I spoke about, insurance barriers, and having culturally sensitive staff who can speak the language or having good interpreter services has been key, especially, like I said, when we have here in our practice patients from all over the world who are coming. And also, I do find the reducing barriers, just like Dr. Gandhi was speaking about, in ways that help patients sort of get over daily protocols that are difficult, having a scheduled appointment for those patients. She mentioned it in their pop-up clinic. And I will say, in my residency training, did a rotation at Ward 86 because I was so inspired by UCSF. They've always been on the forefront of HIV care. And actually, a year ago, we had a young woman with cryptococcal meningitis who'd been in hospital throughout her pregnancy. Dr. Shaik may remember her. And the way that I was able to get over the insurance barriers and actually hospital barriers to getting her on injectable cabotegravir rilpivirine was actually by pointing to UCSF and the work they've done with their homeless population that has been able to control viremic patients with the injectable ART. And so we were able to get this young woman controlled where she had been not controlled for years with her HIV. And so I think being able to work with the patient where they are, I think, is so critical. And I think you see examples of these in each of these sites, Dr. Gandhi and Dr. Shaik's, being able to work with them on a personal level. And I think also being able to listen well, like Dr. Shaik was talking about, whether you're sitting in person with them, but also being able to understand what are their stigmas, whether they're hiding their medication bottles at home, whether they're seeking care outside of their neighborhood. Many people come to us from other counties in New Jersey because they don't want to be seen going into an HIV clinic. So I think being aware of what is the stigma in that for that individual or for that community, and being able to address it is key.